Is that better? Can you hear me now online?
Yes, I can hear you now.
Great.
Yeah.
Thank you. Sorry about that. I did not realize we
Just
were
go ahead and
muted.
start over.
Yeah, okay. So this is a pretty busy slide, but it's going to be talking about how the stroke in young people is starting to look more like stroke in older people. When we look at the rate of hypertension over the last 20 years, it's increased significantly. When we look at obesity, much more pronounced in younger people. And this is for both males and females. The rate of atrial fibrillation has also increased, but not significantly. But other things like diabetes, obesity have increased. So when we talk about this ESIS, this embolic stroke of unknown source, um, as I said, different countries have different rates, different hospitals have different rates. That can be a limitation to what resources you have available. You may not be able to get a transesophageal echocardiogram on a weekend or at all. So you make do with what you have available. And when we look at this largest cohort that has been done for the young ESIS, this just came out earlier this year, it showed a couple of things. One is that the annual rate of recurrent stroke is about 1.9% per year. And when they did have another stroke, it also looked embolic. So that is in one way reassuring that we were correct the first time in saying this was an embolic stroke or embolic appearing. But it's also frustrating because we didn't do something to prevent that second stroke from happening. So the majority of the time, their second stroke was also categorized as ESIS. So they didn't get an answer the first time, they didn't get an answer the second time. But they also noticed a couple of other things, and that is that the prevalence of PFOs were greater in this population than there were in the general population. And not only that, but the patients who had the PFO also had less hypertension, less diabetes, less hyperlipidemia, and a lower BMI. And so that kind of leads us to this idea of the stroke is not because of these increased risk factors for this population, but possibly more to do with the prevalence of this PFO. So here is a case that we typically would see, a 40-year-old with a sudden onset of right-sided weakness. MRI shows this cortical area of ischemia. This is his second stroke. No other past medical history. The echocardiogram, both the 2D and the TEE showed a PFO with a shunt, and then other workup is unremarkable. And so a loop recorder is placed. We look for atrial fibrillation. There's no atrial fibrillation seen over 6 weeks of monitoring. And so now this patient, of course, asking, should I have this hole in my heart fixed? And of course, there's some other questions we may want to ask, was the hypercoagulable state fully investigated? Did they check for, did we look at all the labs available? Did they look for lower extremity Doppler to see if there was a DVT present? Is there anything else that we need to know about his history before we proceed? So when we look at the PFO in patients, there's 18,000 between the ages of 18 to 60 in the US annually that have a PFO and this cryptogenic stroke. And PFOs are the most common right to left shunts. There are some others, but the PFO is going to be the one that we're looking at most significantly, especially in the hospital. And we know that about a quarter of people have a PFO. and it's not always causing a stroke, right? A lot of people have this asymptomatic PFO. We all have it in utero, but as we after we're born, some people still have it. A lot of people still have it. So how do we know whether it's significant, and can it first of all even be the problem? Well, we know that the mean diameter of the persistent PFO is just under 5 millimeters, and that is going to be large enough for emboli that can occlude the middle cerebral artery, which is 3 to 5 millimeters at its stem, as well as some of these major cortical branches as well. And so I'm going to let
So, as Michael stated, patent foraminal valleys are fairly common. Almost 20% of the population has a patent foraminal valley. Essentially what happens is during fetal circulation, fetal development, that defect is important to maintain the fetus's circulation. But when the person is born, by that time, usually the septum primum and the septum secundum have fused and closed that defect, unless you're the 20% of the population where it does not fully happen. And you remain with a small flap and an opening, which is the patent foraminal valley. Now, oftentimes, this is like essentially a flap where oftentimes, even if you have a patent foraminal valley, it remains closed. But certain hemodynamics, such as pressures on the right or left side of the heart, can affect whether this opens or closes. Other maneuvers like Valsalva, different exercise or activity can also lead to this flap opening or closing. So just because someone has a patent foraminal valley doesn't mean it's always opening or always shunting, but different states, physiological states can affect that. And that's sometimes what we find is when these become, the causal agent in a stroke, the patient may have been doing some sort of activity that involved Valsalva or heavy lifting or exercise, which allowed a moment of time when that flap remained open and an emboli passed from the right to the left side of the heart. This is just a schematic showing a small little clot going across this defect. So, the question comes up, okay, so someone has a PFO and they had a stroke, so is it the PFO's fault? We look at a number of different conditions and clinical characteristics and anatomical features to decide how risky was this PFO, or how likely was it that this PFO was the causal agent. If someone already has a disposition or presence of a venous thrombosis and they had the stroke, then this increases the suspicion that this PFO led to their stroke. So that's your patient that had a stroke, you do their workup, hey, they also have a DVT going on right now. That makes you suspicious that that DVT could have been the venous thrombosis that led to the stroke that crossed over from the right to left circulation. Other venous hypercoagulable states can increase the likelihood that the PFO is causally related to the patient's stroke. And the venous thromboemboli, as we mentioned, can pass through the PFO. This is as opposed to other mixed arterial or venous hypercoagulable states, which could cause arterial thrombi, but this would not necessarily involve the PFO because it's already on the arterial side, the left side of the circulation. And we often get the involvement of our hematology colleagues and do hypercoagulable workups, but we do have a number of different conditions we test for. These include protein C and S deficiencies, factor V Leiden, prothrombin, antiphospholipid syndromes, and hyperhomocystinemia. Some of these are venous thromboembolic states, some are mixed, some are purely arterial. So it's important to know which one is positive when you do this evaluation. The other thing that may lead you to be suspicious that this PFO was at fault was if you have a significant right to left shunt. So on your echo reports, you often see, okay, this patient has a right to left shunt, or they have a significant right to left shunt, or they've quantified in some way. So the greater the volume of the right to left shunt across the PFO on imaging, such as a transesophageal echo, the greater the chance that a VT swerved across the interatrial shunt, because you know that this is a common occurrence, so there's a significant amount of fluid or material going from the right to the left side of the circulation. Another suspicious or high-risk feature of a patent foraminovaly is when it is associated with an atrial septal aneurysm. And I'll show you some images of this, what this means. But this is just a description of what the atrial septum looks like and how it behaves and the anatomy. And it's essentially an aneurysmal flap that just is moving left to right. And in this area, we tend to see the development of a stasis or a static flow, and that can cause local thrombosis near the PFO tunnel. And that local thrombosis can lead to a clot, and that clot, if it's sitting right next to a PFO tunnel, may shunt across and go into the left circulation. Of course, when we're thinking about PFOs and if they're at fault, we're looking at what is the recipient brain artery or territory that was affected by this embolism. And we also rule out other risk factors for atherosclerosis. In 2022, the Society of Coronary Angiography and Intervention released very specific guidelines for the management of PFO. So SCI is one of the societies that has released guidelines. There's a number of other societies, including the American Heart Association and a number of the neurological associations as well. But this was a very good set of guidelines that involved a multidisciplinary panel, including neurologists as well as structural cardiologists and other experts in the field. And in the end, in this guidelines, we have basically a consensus statement that in patients 18 to 60 years of age that have a prior PFO-associated stroke, the guideline panel recommended PFO closure rather than just antiplatelet therapy alone, independent of patient anatomy. So we talked about some of the high-risk features of the anatomy a patient may have, which is certainly increases your suspicion that the PFO may be the causal agent. But even independent of that, there are scenarios where you close the PFO. Previous guidelines and other organizations here in 2021, emphasize more of the high-risk anatomical features to guide your decision whether to close this PFO or not. And I know you were involved in the 2020 AAN guidelines as well. Do you want to say something about that?
So so I was doing work with the American Academy of Neurology as part of their guideline development and dissemination subcommittee. Did this for 6 years, and it was a wonderful experience. And right at the end of that, I'm going to skip ahead here just for a second. So right at the end of that, we had some of the data start to come in from longer data from the REDUCE trial, and then, the RESPECT trial, and then a couple of new trials that were coming in as well. And so that led to this this new report that was led by Dr. Gary Gonseth and Dr. Steve Massey. And Dr. Gonseth is probably one of the 10 most influential neurologists that is alive today. And a lot of people probably have not heard of him, but his work is in pretty much every guideline that the American Academy of Neurology produces. And so I have a ton of respect for him. So the REDUCE trial was showing that there were 664 patients, and they had PFO and an embolic looking cryptogenic stroke, and they had that 2-to-1 ratio of closure to antiplatelet therapy, and that had a rate difference of minus 1.32% per year. In the RESPECT trial, when the longer term data came out, that had a rate difference of negative 0.47% per year. The closed trial had 663 patients aged 15 to 59, and that was 1:1:1 of aspirin, anticoagulation, or PFO closure. And they showed a rate difference of negative 0.78% per year. And then they had the defense PFO trial, and this was 120 patients in South Korea, aged 18 to 80. Again, embolic appearing cryptogenic strokes, large PFO, or with atrial septal aneurysm to closure or medical therapy. And medical therapy could be either antiplatelet or anticoagulation. And there were no strokes in the closure group and a rate difference of negative 3.57% per year. So individually, each of these studies did not have the power to really drive strong recommendations. They were good, small studies with some significance individually, but when they were combined into this meta-analysis, that showed significant power to drive a strong recommendation. And that led to this practice update from the AAN in 2020 saying patients who have a foraminal valley after stroke should be considered for PFO closure after appropriate evaluation by both a stroke neurologist and a cardiologist, and to be advised about its risks and benefits. So really that combination between cardiology, neurology, and the patient, making sure we're all together in this decision-making process is going to be very important. So I'll come back here. I don't know if there's anything else you wanted to talk about for this.
So just to reiterate, so after these pivotal studies and the late analysis of these studies and the meta-analysis of these studies, we have come to the conclusion, and the guidelines of many of our societies have supported this, that in patients around the age of 18 to 60 years of age that have non-lacunar ischemic strokes of undetermined cause, the so-called cryptogenic strokes, despite a thorough evaluation and may have a PFO with high-risk anatomical features, it's reasonable to choose closure with a transcatheter device for these patients to prevent recurrent strokes. And some version of this is what all 2 or 3 of these main guideline committees have reiterated. So, and I think Michael just reiterated this, is basically, it was a new data that, combined these studies, the meta-analysis that led to these conclusions. And this basically has led to the birth of the heart-brain team. We collaborate, as a structural cardiologist, as a stroke neurologist, to evaluate each of these patients individually, looking at their entire clinical history, reviewing their imaging, their brain imaging, their cardiac imaging, and making a determination whether they meet criteria for PFO closure. And so any patient, before they get a PFO closure, is evaluated by myself and Michael in detail. And we meet on a regular basis. Almost for the past year, we've been meeting. We've probably looked at, I'm pretty sure, probably over 100 patients. We're happy to look at any patients that you all come across, whether in the hospital services or in outpatient services. And we'd be happy to review them. And if we feel like, the review is favorable to consider a PFO closure, we do in-person visits and consultations with them at that point. And at that point, not all patients will meet the criteria, but at least we've evaluated the patient, we've documented this for future reference. So if they carry a diagnosis of a PFO, everyone in the future can know that they've been evaluated and they don't need closure, or they may have qualified for closure but declined it or didn't qualify, whatever the case may be. So we've kind of documented that, educated the patient, educated their providers as well. As a part of that workup, which you guys are very familiar with, often starts in the hospital but continues on into the outpatient setting. I think Michael wanted to talk a few things about this as well.
Yeah, so one of the things is, as I said earlier, every hospital has different ways of working up stroke. Every provider is going to have different ways of analyzing. We've been logged off on Zoom. Different, okay. Is Zoom still on?
It is. I can
Yes.
hear you.
So way to, okay, there we go. So there are some basic recommendations that are put forth, and this was from the Journal of Stroke, talking about a reasonable approach. And at U of L, we have a similar approach that we use for cryptogenic strokes with PFO. And we will do our standard stroke workup, which is in a different document. But if we know a cause, then great. There's our, they have atrial fibrillation. They come in, they're in new onset atrial fibrillation. They've had a stroke. Whether they have a PFO or not, we've identified our cause, and our workup is complete there. But if they fall into this cryptogenic category, then we will calculate the rope score, and we'll get to that here in a minute. And if the rope score is higher, then we know that they're going to be a better candidate for PFO closure. If it's greater than 7 or greater, then they are a very good candidate for PFO closure if they are in this cryptogenic category. But there is benefit with a rope score less than that as well. So if someone has a rope score that's 3 or less, that means that there is essentially a 0% chance that that PFO was the culprit. And we, barring any significant other exam findings or, that we would say that's not the cause, and not recommend closure. As we mentioned earlier, we've evaluated well over 100 patients to this point. The vast majority of them are not going to be recommended for closure, but we do have some that are. And so when we talk about here, let's talk about the rope score, because I've mentioned it a couple of times and I haven't really explained what it is. So it assesses the likeliness that the stroke is from the PFO. And you get points based on a lack of history of hypertension, diabetes, previous stroke, smoking, presence of cortical infarct, not the lack of the actual presence of a cortical infarct, and a younger age. And where some people get tripped up is the higher the rope score, the more likely the stroke is from the PFO, but the less likely they are of having a recurrent stroke. And people ask, well, why is that? Well, think about it this way. Who's more likely to have a future stroke? The 25-year-old who has no risk factors, but does have a PFO? Or the 85-year-old who smokes 2 packs a day, has uncontrolled hypertension, diabetes, and has a lacunar infarct? Of course, it's going to be the higher risk is going to be the latter. And the former is the one who's going to have the higher rope score and have the greater likelihood the stroke is from the PFO and the greater benefit from PFO closure.
This is just here an image of what an atrial septal aneurysm looks like. And that's basically this hypermobile interatrial septum. It's like a flat or like a curtain that's kind of just drifting in the wind. It can go this way, it can go that way. And this is just a higher risk feature. It can be a nidus for low flow state or thrombosis here in this area near the atrial septum, if it's associated with a PFO as well. That's what it looks like. And then there's certain criteria about how much this flaps back and forth, whether it's considered an aneurysm or what type of aneurysm it is. That's what we mean by the interatrial septum, atrial aneurysm. And you may see this on a lot of your echo reports mentioning an atrial septal aneurysm. So if you see that, that is a high risk feature. And here's the classification criteria, which you'll sometimes also see noted in our echo reports. So one thing to note is that if you have an incidental atrial septal aneurysm and the patient did not have a PFO-associated stroke, you should not close that PFO. So just because the patient has an intraatrial aneurysm doesn't mean the PFO should be closed, unless the patient has a PFO-associated stroke, and then you go down your normal evaluation process. So in isolation, an atrial septal aneurysm is not an indication for intervention. But in the context of a PFO-associated stroke, an atrial septal aneurysm is a high-risk feature. We mentioned this already, right to left shunts also are a risk factor, a high-risk feature. And we've talked about atrial fibrillation. So all of our patients that we're evaluating for stroke and also for PFO closure are going to be monitored for atrial fibrillation, usually about 4 to 6 weeks of cardiac monitoring after their stroke. And if they're identified to have atrial fibrillation, then as far as the PFO story goes, we stop right there. We do not consider it a PFO-associated stroke typically. In older patients, the burden of AFib is higher, but in these younger patients, actually it's very rare to find AFib in these cryptogenic strokes in young people. But we still do monitoring for about 4 to 6 weeks prior to consideration of closure. That's typically done with a cardiac monitor. The best type of cardiac monitor right now we have is these implantable loop recorders. It's basically the size of a small, even smaller than a USB drive. It goes right under the skin and can last for about 2 years and record for almost 2 years. It can stay in permanently, you can have it removed, but these are very nice to put in and provide a lot of information for the patient. And we often do these during the index hospitalization. So if the patient is admitted with a stroke, our preference is before they are discharged to go ahead and get the loop recorder. Now, we may not be considering them or even doing a PFO closure for several weeks or months, but if they get that loop recorder during that index hospitalization, we're ahead of the game at that point, as far as our evaluation goes. And again, as I mentioned, if you identified a patient with a stroke, they have a PFO, and now you found AFib, that pretty much rules out PFO closure in most of those patients, unless there's something very atypical happening. I wanted to make a quick mention that we do have some patients that are evaluated for PFO closure, they don't have AFib, and they qualify for PFO closure and undergo PFO closure. Rarely, but it is documented, and I've seen this before, that post-device implantation, some of these patients have had atrial fibrillation. And this is typically device-related. There is some local irritation and inflammation that can happen at the atrial septum after you put in one of these percutaneous devices. And that is usually short-lived, and it usually resolves as soon as the area becomes endothelialized. So it is something we may see. It does not suggest that the original index stroke was due to atrial fibrillation. And again, it's probably just device-related, it's short-lived, and it will go away typically. Just something to note. If you ever see a patient that has atrial fibrillation post-device implantation. Yes, sir?
The reason that AFib precludes PFO closure, is that because the presumption is that AFib is the cause?
Yes. Correct. Presumption. Correct. It's just if someone has atrial fibrillation, the presumption is that was more likely the cause of the patient's stroke than something like a PFO.
Is that because you can't generate a right to left shunt?
No, you can still generate a right to left shunt, but I think the etiology of AFib leading to stroke is much more common than the PFO leading to it. And at this time, the PFO-related strokes are essentially a diagnosis of exclusion. So we exclude all these other causes, including atrial fibrillation, hypercoagulable states, atherosclerosis, carotid stenosis, and basically it's a diagnosis of exclusion. Michael, if you want to add anything?
And I think also if you're going to be anticoagulating someone because they have the atrial fibrillation, the chances of the stasis resulting in a clot formation is going to be less likely, although it still will be. There's still a chance for that. Yeah.
So I wanted to kind of just quickly guide you through what a PFO closure procedure looks like. Is there any other questions at this time? Anything anyone wanted to comment on before we? Yes, sir.
Yeah, pulmonary hypertension.
Mhm.
How does that, that would increase the risk of
It would, absolutely, yeah.
And so if that is under treatment some other way,
Mhm.
or they're
Yeah.
or something that lowers pulmonary vascular.
Right, right. So, pulmonary hypertension is one of those things that can be a long-standing issue. We've also seen sometimes patients are acutely have some issue where their pulmonary pressures go up, and that's sometimes when these right to left shunts are actually unmasked. They always had a PFO, but suddenly for some reason their pulmonary artery or right-sided pressures have gone up. Then you start seeing the shunt and it can have clinical sequelae. Of course, the patient has advanced pulmonary hypertension. In some cases, that is a contraindication to closing any type of right to left shunt, because by closing that pop-off valve or that pressure release mechanism, you could actually cause right heart failure. So if a patient has advanced pulmonary hypertension, we often do not consider any type of septal closures on those patients. That may actually exclude them.
But then maybe anticoagulation would be.
Anticoagulation, correct. Correct, absolutely, yeah. No, absolutely. Yes, sir. I think they're going to have routine follow-up. As far as specialized follow-up, so if it's just incidentally noted, the patient has an echo for some reason, it's just a finding, I don't think they require any particular follow-up, and the clinical significance of that is very low. It's nice to know, if a patient in the future has a stroke or some issue, but it's fairly common enough that we don't have to do anything particular if it's just an incidental finding. Yeah. It has some implications for if the patient ever needs to have a transseptal puncture procedure. It's very hard to do that. It's more challenging technically, but just from an average patient on the street, I don't think we do anything in particular for that. So, transcatheter PFO closure is performed under conscious sedation. It's guided by fluoroscopy and intracardiac echo. You can do it under transesophageal echo guidance, but I don't. I typically just use intracardiac echo. It requires bilateral femoral venous access with percutaneous sheets, and it usually takes less than an hour. I do them mostly at University Hospital, also at Jewish Hospital. It's usually a same-day outpatient procedure. And I'll let this video play. This is actually a video under fluoroscopy of a PFO closure device being deployed. It's going to loop here. So this thing right here is my intracardiac echo, this little flat metal panel. So this goes in through the left femoral vein. It's like a catheter with a stiff tip at the end. And I park it right here near the right heart, and I'm able to image, this whole area under echo. So you basically put a wire up into the left atrium across the PFO. The PFO is right about here. You put your device, you deploy a disc, that's called the left atrial disc. This is the left atrial disc. And you pull the device back to get the left atrial disc snug up against the septum. Once you're steady, snug, stable right there, you deploy another disc right here that goes on the right side of the septum. So you essentially are sandwiching the septum. One disc on the left side, one disc on the right side. And that's what they're showing here is the left disc being deployed. And then you release the device. And you're done. Let's let it loop one more time here. Again, this is the wire, the device being placed in the left atrium, left disc being deployed. You guys can see it okay. Snug up against the septum, you deploy the right disc, lock the device, and release the device.
So we can see the wire, but there's some sort of fabric or something in between.
Correct. As far as the disc go, Yeah, so these under X-ray, all we're seeing is kind of like the wire frame of the device. I'll show you a picture here. This wire frame is basically inside of a fabric device. Yeah, to seal. This is all enclosed by fabric, actually. And I mean, that was under X-rays. This is what it looks like under echo. So this is with intracardiac echo. This is the other screen. So you have two screens up. One is the X-ray screen. One is this echo screen. And we're basically, let's see if I can let it play here. Same thing. This is the disc here. This is the other disc, and you're sandwiching the septum. Here's the septum. At the top of your screen is where the right atrium is. The bottom of the screen is the left atrium. And this is the septum right here in the middle. So right atrium, left atrium, here's the septum. This is where your PFO was, and this is the disc. One disc goes here, one disc goes here, sandwiches the septum, and then you release the device. Let it play here one more time. And this color here is just showing you where the tunnel is for the device, for the PFO. Here's the device coming in. One disc, second disc, sandwich, and then release. And this is just a still image of what an echo looks like. Again, the top of your screen was your right atrium, left atrium. Here's your septum. This here is your tunnel, the PFO tunnel. And this is the device sandwiching this tunnel they're showing in this image down here.
I don't think the device is showing.
Oh, I'm sorry. Well, hopefully you're able to follow that. Absolutely. But right here, I mean, this is where the device is sandwiching the septum. And this is, as you were commenting, this is what the device looks like. It has this wire frame, but it's actually a fabric. Panel C is one of the typical devices we use, and that's, as you can see, it's just a wire frame with fabric covering the frame. There were a number of iterations of these devices over the years, different companies, different products. But there are essentially two main products that are commercially available in the United States right now. So I think we touched on most of this, treatment options for cryptogenic stroke with patients with PFO, obviously the percutaneous PFO closure devices. Really rarely patients get surgical PFO closures. That's only in the setting of other cardiac surgery that they're having. Nobody typically gets isolated surgical PFO closure anymore. There are options for antiplatelet and anticoagulant therapy, but our guidelines have suggested that percutaneous closure has more benefit than these. And percutaneous PFO closure has been around for quite a while. The first occluders were actually introduced in the 1970s, which is 2 years before coronary angioplasty. So it's not a new technology. The technology itself has been out for quite a while.
And so before we actually get to this slide, did you want to talk about one of the questions that I had was if there is atrial fibrillation after the PFO has been closed, one of the first thoughts is, should we anticoagulate with that, similar to what is done with the Watchman device?
Yeah, so after implanting these percutaneous devices, we do not typically need to anticoagulate the patient. The typical regimen is to give them antiplatelet therapy. So some of the original trials, I think it was a reduced trial especially, they gave them dual antiplatelet therapy for 1 month post-device closure. And then you would drop the Plavix and just keep them on aspirin for another 5 months, so a total of 6 months. So usually you're committing these patients to dual antiplatelet therapy for 1 month, and then antiplatelet therapy for another, up to 6 months. Anticoagulation is not typically indicated post-device closure from the device perspective. Of course, these patients may have other indications for anticoagulation if they have, DVT history, pulmonary embolism history, etc. You mentioned the Watchman device, which is a topic in itself. Maybe we could do that another time. But as you guys may know, the Watchman device is a left atrial appendage occluder device. It is an alternative to long-term anticoagulation for patients with AFib that cannot tolerate long-term anticoagulation. And in that case, we used to, for those, and we still sometimes do, place the patient on anticoagulation for the initial phase after the device implantation to ensure that the device doesn't develop any thrombosis or clot on the device and help the device heal in or endothelialize. But even now with the Watchman device, we're able to just use dual antiplatelet therapy for most of the patients post-device implant. So in summary, we don't need to anticoagulate this patient just because they get a percutaneous device at this point.
Yeah, I know that was important for me because we have a lot of patients where they can't tolerate anticoagulation, and knowing that maybe they don't need it is certainly helpful. So if anyone has a patient that they would like to have evaluated, you can either contact either of us directly, or you can call our offices. The number's listed there. You can always contact the stroke team or the structural heart team for a consult in the hospital as well. And typically during the hospital, we'll want to get a good structural look at the heart. With any stroke patient, we try to do that anyway. And then as we mentioned, we would like to get the ball rolling and get a extended cardiac monitor. And we do that as part of our routine cryptogenic stroke workup anyway, in terms of extended cardiac monitoring. That can either be with an implantable device or with one of these little stickers, little patches that people can wear for, that's usually shorter duration. The studies and the guidelines don't specify how long the monitoring should be done. Some of the trials were just looking for people as short as 24 hours, and we do a more thorough evaluation because if someone doesn't need to have a procedure done, I don't have the belief that they shouldn't have it done. But for those patients that can benefit, we do want to give them as much information so they can make an informed decision and be a part of their health care as possible. So for people, here's the CME code. And we have time if there's any questions, we're glad to help answer them. Sorry. Yeah.
So if we find the PFO on a transthoracic echo, should we get a TE for closure versus outpatient?
I would say, with a transthoracic echo, you can have a suggestion or indication that the patient has a PFO, but you can't actually make the full diagnosis of a PFO on a transthoracic echo. So on transthoracic echo, you're typically just seeing that there may be a shunt, like a positive bubbles study, that you're seeing bubbles from the right side go to the left side at the atrial level. That can be deceptive in the sense that it may not be a PFO. It could actually be an atrial septal defect, an ASD, or some other anatomical issue, or it can even be an intrapulmonary shunt. So if there is this clinical suspicion or evidence on a transthoracic echo of a PFO, we would need to get a transesophageal echo, a TE at that time. Also, to assess the PFO itself, what's the anatomy of the PFO? Does it have high-risk features? So those will be all the things we'll be looking at to make that decision. So yeah, if it can be done during the index hospitalization, that's probably better. Yeah.
And of course, that's only if you're suspicious that the PFO could be the cause.
Correct,
If there's an 85-year-old who, as I mentioned, with uncontrolled smoking, hypertension, and they have a PFO, no need to pursue that.
Thank you all very much.
Thank you, guys.
Appreciate it.
Yeah, thank you.
Talk to you soon.
I'll see you
hopefully.
tomorrow.
Yeah, tomorrow morning. Perfect. You got work today?
Yeah.
I got the source service.
Don't forget.
All right, thanks a lot. See you later.
Thank you. I'm sorry that we didn't have the audio on to start. I told,
Oh, really?
yeah,
I didn't know we have a,
yeah, someone called Hannah and was like, you know, hey, we can't hear.
Oh.
So it was only like the first like 7 minutes or so.
oh,
But,
good. Well, if you want, I can just post on MedHub your lecture.
Sure.
Okay?
Thank you.
All right. Thank you so much.